Is everyone happy for me to make a start? Just want to make sure that we stick to time so everyone can leave for 8:30. So thank you so much everyone for signing up for the social, cultural and clinical aspects of female genital cutting education session. My name's Sarah Lorimer and I'm the team leader of Section Reproductive Health at Gen West. I'll explain a little bit about who we are and also the partners that have supported this, Women's Health in the North and the Northwest PHN as well, and introduce all of our speakers in a moment. Before we do go any further though, I would like to start this session with an acknowledgement of country. Gen West Women's Health in the North and the NWM-PHN recognise that the land on which we work and the land on which we provide our services always was and always will be Aboriginal land. And we all would like to pay our respects to elders past and present and proudly acknowledge the Aboriginal and Torres Strait Islander communities across Melbourne's northwest, their rich cultures, diversity, histories and knowledges, and the deep contribution they make to the life of this region. So I work at Gen West, which is based in Footscray, and we're also joined by Women's Health in the North, which is based in Thornbury. We're organisations that work towards gender equity, which is a key aspect of work in sexual and reproductive health. The work that we do includes providing health education to communities in the Northwest region and advocating for sexual and reproductive health rights. We work in partnership with women's health services across the state, as well as partners in community health, local government and health services. So two of our speakers today are our FARP health promotion coordinators, Shakriya Alui, who works at Gen West, and Intisar Ahmed, who works at Women's Health in the North. Shakriya is a long-standing staff member at Gen West, and her role involves working with health professionals and services to develop and deliver professional development training to build their capacity and ensure that they provide culturally appropriate services to women in the community. Intisar is a health promotion officer at Women's Health in the North, and she's responsible for delivering the Family and Reproductive Rights Education Program. She works with a wide range of women, girls, health professionals and local governments and is committed to educating the community about sexual and reproductive health and making a difference to women's health and well-being. I'm also going to introduce our other speakers who've joined us this evening. We have Mari Jones, who's the coordinator of the African Women's Clinic at the Royal Women's Hospital. Mari is a nurse practitioner and midwife at the Royal Women's. She has a postgraduate degree in public health, specialising in sexual health, and is the associate nurse and midwife unit manager and coordinator of the African Women's Clinic. Also joining from the Women's is Rosie Downing, who's a midwife and nurse. Rosie's worked in a range of healthcare settings from remote communities in Central Australia as a midwife and women's health nurse to tertiary hospital midwifery group practices, as well as public and private home birth models of care. And then last but not least is Joanne Gardner, who is a refugee health GP that works at CoHealth. So Joanne is a GP with a long-standing interest in refugee health, and she's a founding member of the RACGP Special Interest Group in Refugee Health. Joanne is also a member of the Victorian Refugee Health Network and the Refugee Health Network of Australia, and she's been very involved in the education and advocacy around FGC for many years. So thank you to all of our speakers for joining us. Throughout different points in the evening, they'll each be speaking, and I'm going to pass over to them soon. I'm just going to run through some housekeeping to let people know that during the session, all attendees will be muted. If you have questions, there will be time because we've allocated a session at the end for Q&A. So any questions that you have, please pop them into the chat and we'll make sure that those are answered at the end. And also just to let you know that this session is being recorded, so questions can be asked anonymously to protect your privacy if that's what you would like. But Also, because the Zoom is set up as a meeting, there'll be opportunity for an open discussion at the end as well. Another thing to make sure is to please make sure that the name I've signed in with on Zoom is correct, so that Emily from the PHN can mark your attendance. And that's needed because certificates and CPD will not be issued if they can't confirm your attendance. So please ensure that your full name is in your Zoom. We're just going to pop up now how to do that if you aren't sure. We'll just give you a moment to make sure your name is accurate. All right. So an overview of tonight's session. We're going to be introducing female genital cutting, as well as providing an overview of the FARRET program, the Family and Reproductive Rights Education Program in Victoria, and getting insight from Shakriya and Intisar on providing culturally sensitive support. Then Mari and Rosie will be talking about clinical services available at the Women's, and then all speakers will be participating in the discussion and Q&A at the end. All right, I'll pass over to you, Shakriya and Intisar.
Thank you so much, Sarah. Good evening, everyone. My name is Intisar. As Sarah said, I work at WIN as Health Promotion Officer. I would like also to acknowledge the traditional owners of the land on which we're meeting today. In my case, it's the Wurundjeri Kulin Nation. I pay my respect to all those past and present, and any person, a particular person that attending this meeting. So part one of this presentation is introduction to female genital cutting, which is include definition and terminology, prevalence rate, history of FGC, certain reasons for practice, human rights frameworks. The overview of FARRET and providing culturally sensitive support, and that's going to be presented by Shakriya. Part one is going to be presented by me, which is included, it's going to include overview of FARRET again West and Women Health in the North, working with communities, who have migrated from communities, from countries with prevalence of FGC, barriers to sexual and reproductive health, services for women who have migrated from countries with prevalence of FGC, referral pathway, and existing resources and clinical guidelines. Okay, so the UNICEF states that over 230 million girls and women have been cut. Africa accounts for the largest share of this total with over 144 million. Followed by Asia, which is over 80 million. Further 6 million are in the Middle East. Another 1 to 2 million are affected in small practicing communities and destination countries for migration in the rest of the world. The Australian Institute of Health and Welfare has estimated that about 53,000 women and girls currently living in Australia, but born elsewhere have undergone FGC. This estimate was calculated by combining available international FGC prevalence rates by country with Australian migration data. This methodology has several major limitations, such as assumption that population that have migrated to Australia are representative of the survey. Population used to generate the international prevalence rate. Nevertheless, the estimate does provide a theoretical account of the potential number of women and girls living in Australia who might have undergone FTC. The practice is also documented to be found in Iraq, Oman, the UAE, in India, Indonesia, and Pakistan. Okay. Please tell me about the next one. So the definition of female genital cutting or female circumcision is all procedure that includes partial or total removal of female genital organs or other injury to the female genital organs for non-medical reason. This is not a test and it's not an exam, but it's like a discussion question that we would like you or we would appreciate if you put some answers in the chat box. That's Tilly and Sarah gonna mine. So the first question is, what do you know about FTC? What have you heard about the history of the practice? I'll give like a few seconds. It doesn't have to be long. And then we appreciate it if you put something in the chat box. Thank you. And I go to the next slide, please. Thank you. So it has been started in Egypt back to the 16th century in Roman times. It was used as a form of infibulation, where you use for female slaves and as a form of contraception. Also in the United States, in 1890s, FTC was practiced by doctors to cure female weakness. The Western countries, including England, have used FTC to cure women of psychological alignments. Thank you. Next slide. The next question is, do you know at what age the procedure is carried out or performed? Thank you. Really appreciate it if you put something in the chat box. Can go to the next slide, please. Okay, so it depends on where you live, where you come from, the ethnicity, your communities. There's some people that perform FTC newborn, during childhood, adolescence, just before marriage, during the first pregnancy. But known as like, the major communities that practice FTC would be like between 5 and 8 years old. Okay, this is an interesting discussion question, which is we've got here 3 terminology, and terminology is really important for health professionals, which terminology we use, especially when we're working with women experienced FTC. So we have here 3 terminology. If you can tell me which one would you use when you work with women experienced FTC for anything, like, attend your clinics for any reproductive system health, so like checkup or which one would you use? Thank you. I would really appreciate it if you put something in the chat box. I really appreciate if everyone put something for this one, because it's really important. Okay, thank you. So the terms that the engaging terms, effective terms, when we're working with the woman is female circumcision, followed by the other terminology, which is traditional cutting. You can, the World Health Organization and other organizations that are working with, with FTC, they use the word mutilation to reinforce the harm caused by the practice and retreats that it is gender-based human violence violation. And also it's okay between you, like amongst the health professionals to use the word mutilation if that's what you believe. But it's gonna be like hard on the woman to use the word mutilation because the woman don't feel mutilated. Yes, it's a bad practice that we need to ban, we need to eradicate, we need to stop, we need to fight not to happen to those little girls, but we don't see ourselves mutilated. So it's very important, as the term mutilation can pluralize communities where the practice is culturally custom. Okay. Okay, so this graph tells us that's where FGC prevalence from high to mild, which is, as you see, the darker color is the higher prevalence. You can see there, like Egypt is 91. And then you've got from the lightest country, Chad, this is 44.7, 44%. So it goes from darker to lighter by higher to mild prevalence. Thank you, Tori. Okay. The next graph will tell us, and this is very, concerning, percentage of girls and women aged 15 to 49 who have heard about FGC and think the practice should end. And if you can see here, all the countries that we saw just in the previous slides, it was with high prevalence. You can see here they are with low percentage of saying no, like shouldn't stop. Another question. I don't want you to feel this is as a test presentation, but it's just when I just have a general ideas of what people know. Do you know what the prevalence rate of FGC is in Victoria? And I think you can straight away go to the next slide, Tilly. So it's difficult to estimate because we have no data. However, there is high settlement of women and girls from countries where FGC is prevalent. Thank you. This is another graph that estimates the number of female living in Australia who were born in one of the 30 countries known to practice FGC between 1998 to 2017. And as you see, it's getting higher and higher and higher. So we have more people. Probably from 2017, it's going to have like even more and more. But we don't have that data. Settlement status of women, and this has been pulled straight from Family Planning Victoria. Family Planning Victoria used to facilitate FARA long time ago, and this research being done, or this data being collected in 2013. I know it's very old, but that's what's the latest we have. And that was female genital cutting by LGI profiles, which is, as you can see, there's every single LGI. We've got quite a few people that, quite a few women that live in that suburb and LGIs. Thank you. Do you know what people's reasons are to get FGC done? You can straight go to the next one. So the main reason is I cannot give a single reason that why communities practice FGC, but there's a whole lot of reasons. So preservation of traditional practice and cultural identity. They think it's their identity because it's been done for so long. Hygiene and cleanliness, they think clitoris is dirty, so they need to cut it. The girls to be clean. Protection of virginity, because it's very important for our culture, the girls to be virgin, like the day that she get married. To ensure fidelity, to promote marriageability and social and economic status, to enhance the husband's sexual pleasure, religious observance, social pressure from peers. It is a rite of passage. It's uphold the family honor. Do you think religious scripture advocate or justify practice of FGC? Really appreciate if you come with some answers in the chat box for this one, because it's very important, because FGC, we talk about it in a bit. Next slide. So FGC practiced by communities and often claimed to be carried out in accordance to religious belief. However, FGC predated Christianity, Islam, and Judaism, and none of those books support FGC. There's nothing that is say you need to circumcise your daughters. Okay. Where do you think the procedure of FGC carried out, and who do you think carries out the FGC? Go to the next slide. Thank you. So usually carried out by an older woman for whom it is a way of gaining prestige and can be a source of incomes. It's also carried out in hospitals in some practicing countries, and their argument is FGC is happening anyway, like in a backyard. So just to minimize the implication associated with the practice, they'll say, okay, we do type 1 as it's really severe. But for myself, I don't think it's a good idea, but that's what their argument is. The procedure includes the girls being held on the floor, usually by a lot of women, and the procedure carried out without medical expertise, attention to hygiene, or anesthetic. The next slide, okay. So there's a lot of organizations and countries working on this to stop or to eradicate FGC. It's the UN, everywhere, United Kingdom, Australia, as you see, we've got this program. And, there's everywhere they're trying to educate the communities, even, the countries that practice FGC. FGC constitutes a violation of the rights of women and girls. FGC violates a number of treaties, covenant on civil and political rights, on economic, social, and cultural rights. It's conventions on the elimination of all forms of discrimination against women, convention on the rights of the child, also relating to the status of refugees, and it is critical relating to the status of refugees. As I said, there's an international response. There's a lot of countries working on it, and also there's an Australian response. We've got a few programs in New South Wales. In Victoria, we have the FAROT. It's illegal everywhere, like, Europe, Africa, everywhere, it's illegal. But the issue is that, especially in African countries, the law is not enforced. So there's no enforcement for the law. And it's medicalized in some countries as part of the harm reduction strategies, like I said before. The international response, as also I talked about it before, is UN General Assembly accepted in December 2012 resolution of eliminate FGC. The World Health Organization published a global strategies to stop healthcare providers from performing FGC in 2010. Research shows decrease in prevalence of FGC has increased the number of women and men support ending of the practice. COVID, like, with other things, with other lot of things that's impacted by COVID. So the FGC been impacted by COVID as well. So it's been increased a little bit because in Africa, online education wasn't supported by the system or by the government. So the family find it an opportunity to circumcise the girls at that time because they're staying home, not study. So they said it's an opportunity to circumcise the girls. So that make it increase post-COVID, and also impacted on the NGO advocacy work. Thank you, Tom. Do you know what the legal status of FGC is in Victoria? So the relevant Victorian legislation is fell under Female Genital Mutilation Act 1996. It's a legal status of FGC. Children Use and Families Act 2005. It's mandatory reporting for people that work with young people. And it's prohibited even to take your child outside or elsewhere and circumcise them and then bring them here. You will get penalty as well. Even if you take them to another state, to another country, it's prohibited and you're gonna face consequences. Thank you so much. That's my end of my part. So I will hand it into Shakriya.
Hi everyone. My name is Shukriya. I'd like to pay my respect to the Aboriginal community, the Aboriginal elders, past and present. I'm going to talk a little bit about the part 2, so the FARAP program, and how you can support women who've come from countries where FGC is practiced. FARAP stands for the Family Reproductive Right Education Program. It was established in 1995. It is to prevent FGC and readdress the sexual and reproductive health needs of women in communities who've been impacted by FGC, and it is based on the UN initiative to eradicate FGC. FARAP at Gen West sits within the Action for Equity team, which is a sexual and reproductive health strategy for Melbourne's West. Works with a range of health professionals to build their capacity to ensure the provision of cultural appropriate services in Melbourne's West, and also improve the sexual and reproductive health and well-being of women from communities who have migrated from countries where FGC is prevalent, and work to prevent the practice. However, FARAP Women's Health in the North sits within the Freedom, Respect and Equity in Sexual Health, which is Sexual and Reproductive Health strategy for Melbourne's North. It delivers FGC professional education session to clinicians and allied health staff focusing on cultural sensitive services provision. And it also works with women from communities that traditionally practice FGC to support their sexual and reproductive health and work to prevent the practice. Working with communities who have migrated from countries with prevalence of FGC. I know a lot of you would know this, the answers to this question, but I just want to kind of see and work out. Do you know what the implications of settlement is to community? Any community, refugee or migrant community settling in Australia, like in Victoria or in Australia? You can share that with me on the chat. Tilly, next slide. These are just some of the implication of settlement that I've put here. African communities where FGC is commonly practiced are not only impacted by the ramification of FGC, they are also impacted by the range of issues that add layers of complexity to African women's lives and can affect their health in many ways. For example, grief is the most common among refugees, where they experience separation or loss of loved ones. Migrant and refugee women are confronted with difficulties in accessing simple things like housing, employment, even like knowing how the bank system works. And some might have even lower or no level of English proficiency. Most communities are not aware or in denial of existing mental health issues, and most perceive that if they seek like for mental health services, they'll be considered by their communities as being like crazy. Most are not aware that FGC is actually illegal in Victoria, and all laws are enforced, not ignored. Younger generation might have different value system compared to their parents or grandparents, and therefore certain traditional practices might no longer be practiced or believed by the younger generation. Next. What do you think are the health needs of women and girls from FGC prevalence communities? Next. These are just some of the things that I mentioned, which is education, counseling, regular gynecological checkups, intensive antenatal and postnatal care, defibrillation reconstructive surgery, which Mari will cover from the Women's Hospital, will cover a little bit on this later on, and menopausal care. Why is it important to work with women and girls from FGC communities is to assist in meeting their sexual and reproductive health needs, who have like migrated from those communities, and prevent FGC hopefully from occurring, improve their health outcome, improve access to services. Traditional African communities, women traditional role is to be good mothers and carers. Pregnancy and birth is mostly women's business. Women rally on female relatives and friends for support during this time. There is a practice that happens where after women has her baby, she stays home for 40 days. It's really hard here in Australia to do that. This is very common in many African communities. But it's a tradition that it's disappearing because there isn't a system of community supporting or families supporting that, because everyone is working and some don't have their families here. Many African cultures is very oral, so information is passed verbally. Health system in many African countries is inadequate. There is no context. For example, having cervical screen is like preventative health is not very common. Health education is very limited. Women experience barriers when accessing health system, different gender roles, expectations, poor health literacy, experience of racism and discrimination. These are some of the things that you can consider when you're working with women or girls in the community or within clients, like you're seeing patients. Be very clear about what you do, your role, your scope, your authority, your responsibilities. Make appropriate referral by knowing what services are available in your area, what they can do. Be clear with women about what is happening at every stage of everything that you're doing. Ensure that they are very informed, and do not assume anything, because FGC comes in many forms. Another thing to consider when working with women and girls is try to use female interpreters where possible. Consult with FARAP workers in the targeted communities, so you can, we can be contacted. So FARAP workers in various places can be secondary consultant, where you can give us a call and have a chat about your client, and we can help and guide you on how to respond to that. You can also, get leaders, community leaders, in your discussion, in your consultation as well. Use welcoming manner, friendly body language, maintain non-judgmental, respectful approach. Have in the back of your mind countries where FGC is most prevalent, but don't generalize. So like Somalia, Eritrea, Egypt, like these are some of the countries I've mentioned here. But there will always be women from these areas or from these countries who would have not had FGC. Therefore, it's very important that we ask the question. Some ways where you can, these are some conversation starters. So I'm not sure who is here, but like if you are working, if you're a GP or if you're working with, if you're a midwife, I guess the best way to ask the question is to make sure that you have some, you've had first interaction with women around, I guess the women are very comfortable with you, and so when you bring this discussion, you know exactly the country of origin, the country of birth. Once you work out that women, for example, is from the high prevalence rate, you can then bring about the conversation and say many women from X, Y, and Z country have traditional cutting. Is it something that they've had experience? Or like, what is it that they call in their language? What is the term used in their language to express that? And then explain that when examining her that it might be very difficult to perform the test, and she would need to be referred to, another specialist clinics. There is a video here that we've attached, but we would send that out at the end of the session. It's a really short video that Core Health put together. It's a cartoon video. It's really helpful in helping and supporting you in asking questions. How to support women? Always use, like I said before, female interpreters on site if you can. We know that's not possible. Reassure the women that the consultation is very confidential and it's private. It might take more than just one appointment. Let the woman know that she can bring a friend or relative to the appointment. Support. Use simple English, explain the test, use diagram, flip charts, and like any, thing that you think it will be very helpful that you might find on the website as well. These are just some of the FAREP services in Victoria. So they're Gen West, Women's Health in the North, Core Health, Monash Health, Darebin Youth Services, Multicultural Centre for Women's Health, the Benue Community Health, and Mercy Hospital for Women. Now I'm going to give Mari, who will go and talk about the clinical services.
Good evening, everyone. I'm Mari. Rosie and I are presenting from the Wurundjeri lands of the Kulin Nation, and we'd like to pay our respects to elders past, present and emerging, and anyone here tonight who is of Aboriginal, help me, Rosie, Aboriginal identifies as Aboriginal. So I'm sorry, the chopper was coming across into the Melbourne and it was very distracting. We're presenting here from the Royal Women's. So this is just a beautiful, one of our many beautiful photos that we have of women who have experienced female genital mutilation, and we'd like to talk about our service here at the Royal Women's. The clinic started way back in 2010. We already had a FAREP program established here. The clinic was originally called the Defibrillation Clinic, which was an executive decision, not a clinical decision from us clinicians. So it's a nurse midwife-led clinic, and we work very closely with our FAREP team in seeing our women and supporting our women. The clinic, I finally had the name changed to the African Women's Clinic in 2015, which I think is a much better name for a clinic. It's still, we do know that it's not just African women that have experienced female genital mutilation, but it was a much better name than the Defibrillation Clinic, which no one had any idea what it meant. So as I said, the FAREP team here at the Women's and the African Women Clinic team are very close. The FAREP workers are our link to the community, and they're our support as clinicians caring for our women in the actual clinic. So if a woman has any questions or she wants to access the service in a very discreet way, she can ring the FARAP service. She does not need a referral to be seen in the African Women's Clinic, and that makes it a lot more accessible to women, which is one of the reasons that the clinic was set up in this way, to make it accessible to women and to make their care as private as possible. Before the clinic existed, women had to get a referral from a GP, then they would be seen in a gynecology clinic, which could take months and months and months. There were 2 obstetrician gynecologists that saw the women, and then if they did need a de-infibulation procedure, they then had to go onto a waiting list for theatre. So I had some wonderful obstetrician gynecologists and manager who thought there was something that we could do that would be a lot more accessible for women. And they had a clinician from the UK, Comfort Momo, who's a midwife, who's an expert in women who have experienced FGM in the UK. She came out and gave a series of talks. We did some community consultation, and the clinic was formed. So as I said, the FARAP team are very important to us. We've had 2 of our FARAP workers leave in recent times, and we're currently recruiting. So there'll probably be a lot of questions about the legal responsibilities. As health professionals, we have to, it's a mandatory notification if we suspect at all that a child might be at risk of being taken out of the country and having FGM performed, or it happening in Australia. There have been instances in Australia. There has been one family in New South Wales that were found guilty of performing FGM in the country. It has quite serious consequences of jail time and a fine, which really isn't what we want for this community. We want the community to be educated and to be supported and to be able to discuss what's happening, because we can't think of anything worse than a mother or family member being jailed because what they thought they were doing was acceptable and out of love. But it is illegal in Australia throughout the states and territories. The consequences are slightly different in each state and territory. And the midwives here certainly ask, when we see the women, we discuss the legalities, but when they do have their babies, particularly if they have a female baby, obviously the midwives here actually do discuss the law and FGM to them to make it very clear. So the FGM is in types. The World Health Organization has given it 4 types. And just going back a step, I, in my presentations, use FGM because I'm talking to health professionals. When I speak to the women that we see, I talk about traditional cutting or whatever other terminology the woman might use, I will use, but I talk about traditional cutting to them. But when I speak to health professionals, I do use FGM. There's type 1, which some women will call sooner. So you might hear that terminology, and that's a type 1. There's type 2, 3, which is, as a health professional, is called infibulation, and type 4. So type 1 is when the clitoris has been cut. It may be cut a little bit or it may be completely missing. Type 1 can be very difficult to realise that the woman has it and diagnose because it sometimes can be very, very subtle. If you're not looking for it, you may miss it. And in all these types, I mean, obviously one will be, as you will see, more complex than the other, but every type of FGM will have some sort of effect on this woman. So type 2 is when the clitoris has been cut and then the labia minora also has been cut. Type 3, again, is the clitoris has been cut, the labia minora cut, and vagina sutured to close with a small hole left for urine and menstruation. But in saying that too, we have done defibrillations on women, and when we've done it, the clitoris and the labia minora underneath are all complete. Every woman is totally individual. This is just an overview, but every woman, I mean, one woman might have one labia minora missing, she may have both. You have to remember that when these, and girls, because they mainly were girls, were cut, they were mostly having had no anaesthetic, being held down and cut. And of course, our women tell us how much they moved and tried to run away. And so just to remember that absolutely every woman is different. And type 4 is anything else, whether it be piercing, cauterization of the vagina, and any other sort of cutting. So the consequences of FGM obviously is pain, infection, bleeding, and death, urinary retention. So we don't know how many girls die of this procedure. It's obviously not recorded anywhere. And the long term is what we see more in the clinic. So different sort of scarring, so maybe scarring on the vulva. We do see cysts, and the cysts that we do tend to see are over the clitoral area. Of course, all complications with their maybe passing urine. We actually don't see a lot of that in the clinic as much as what I thought we would over the years, but they can still have complications with urinary tract infections. Some of the big things that we see are gynecological, with painful intercourse, painful periods, which used to lead to inability to perform cervical screening. It's much better now. We have self-collect that makes it a lot easier. But back before self-collect, it was very difficult for these women to have any sort of what we used to call a pap test. And of course, there might be the consequences of having had an infection after their FGM, which may lead to fertility, pelvic pain, and also discomfort having any sort of vaginal examination. And of course, with childbirth, women have had cesarean sections, and we know that because they've presented to hospital with a type 3 FGM and no one's known what to do, so they've had a cesarean, or severe perineal trauma because the perineum wasn't looked after well enough in the childbirth. And the psychological impacts. I would say most of our women are definitely impacted psychologically, but they are the most amazing women, and many of them put that behind them because there are too many other things that they have to worry about, like their families and their job and getting on with life. And I'm sure there's more of them that are affected, but they're just very, very strong women. Some of the women that we have seen that are very, very affected are when they've had flashbacks when we've been examining them, or started to talk about it. So we've had women that have come to the clinic. It's taken them a long time to get there because it's not a very easy conversation to have. And I know that as soon as, we start talking about it, and we do a lot of ice breaking before we start getting into what they've, experienced. We do a lot of other, chit chat, but you can see it as soon as they start to, you can just see it in them with their remembering. Sometimes there's tears in the consultation because, they are so affected. It can be very, very difficult to have these conversations. We take our time in our clinic. That is one of the best things about our clinic. We can take half an hour. We're never, ever pushed for time. And of course, our women often talk about how they realise that their mum or their grandmother organised this to be done to them, and they're not angry. They know it was done with love, but it's just so sad for them that it has happened to them and had this huge effect on their lives. And marriage and sexuality, like we see women that are getting married and know perfectly well are not going to be able to have sexual intercourse. So they come to us, for a procedure, or they can have sexual intercourse, but it's just not pleasurable for them. So it has huge consequences on our women. And now it's Rosie.
Hello, everybody. I'm Rosie. I'm a midwife and a nurse working in the clinic with Mari. Excuse me for a second. I've got a bit of a tickle in my throat, so excuse me for coughing. As Mari said, I just want to acknowledge that we're talking to you from a Wurundjeri Woi-wurrung country tonight. I want to pay my respect, my gratitude. This country was never ceded. And hello to everybody. Thanks for having me. So, sorry about the cough. One of the things I love about working in this clinic is that it's one of the very few clinics I've ever heard of where women can refer themselves to the clinic in a hospital. They don't need to go and see a GP or go through all of those hurdles that sometimes we need to access healthcare. And we do meet quite a number of women who've heard about the clinic online or from a family member or from a friend, and come themselves, which I really love. We also see a lot of women who've been referred to the clinic when they've come to the women's hospital to access antenatal care, and that conversation's come up through the course of their pregnancy. And of course, if women have gone to see their GP or a healthcare practitioner across Naarm or Melbourne, and then been referred in to the clinic as well. And we see everyone, which I also really love. So as you can see on this slide, we don't discriminate, we don't turn anybody away. And definitely in all of our consultations, no matter where the consultation ends up going, we'll always end the visit by saying, you're really welcome to come back another time. If you ever want to, if there's anyone else that that wants to come to the clinic, you're very welcome to bring them back. Sometimes there's women who maybe we've seen once or twice, and they might, for whatever reason, say, I'd like to come back, maybe I'll come back in a year or two. We really like to leave the door open, because as we've discussed tonight, obviously it's an incredibly sensitive, incredibly personal experience, that people will kind of, want to access healthcare in a time that suits them, as works for them. Can I go to the next slide, please? In our clinic, as Mary said, we do have a lot of time in our consults, which I love, but I actually wish we had more time. We do like to refer to health services or community services as is appropriate for each person that we meet. I wish that there were more services that we could refer to for women who are wanting sexual counselling or trauma counselling as well. As you can imagine, it's, everyone's experience is really different, but a lot of the people that we see, that's a huge kind of source of stress or anguish for them. So we do have a service within the hospital that we can refer to, but you can imagine the waiting list is quite long. And again, we try and tailor our care to each person that we see, because obviously everyone's got a really different experience, a different story, and different things that they're looking for at that particular point in time. I think it was Intisar who mentioned reconstructive surgery, or sorry, maybe it was Ishuka, I can't remember, sorry. Dr. Mansour Makazemi is a plastic surgeon in Melbourne who does do some reconstructive surgery. I won't go into it too much in this presentation, but I guess it's probably helpful for us all to know that it is something that is available and that exists. People can have really varying degrees of success with it, depending on how you would define success. And again, that's really down to each individual's kind of desires and hopes from that surgery. But I just wanted to kind of acknowledge that is, there is a doctor in Melbourne who's doing this surgery. And as you can see, physio, social work, our beautiful FARAP workers, and also our pelvic floor unit. So women who are experiencing any kind of gynecological issues as well, we can refer. I will let you read through this slide yourselves. I'm not going to talk to each point. I think what I would like to share when we talk about impact on maternity care is kind of how I begin framing the conversation with every pregnant woman that I see in the clinic, which is I really like to emphasize that it's not her that's the problem. One of the issues that can arise for women is that she's birthing in a health system that isn't familiar with FGC or traditional cutting. And if she was birthing in the country where she may have been born, or definitely where it happened, the healthcare providers that she would have been seeing for maternity care would be very familiar with it. It wouldn't even be a thing. It wouldn't be something that she's now, whereas coming to Australia, often she's meeting healthcare practitioners who, often may not have even heard of it, may not be thinking of it, definitely haven't really thought through the implications and how that might feel for her, especially meeting them in that moment where she's already, potentially in quite a vulnerable state. She's pregnant, she's in labour, she's giving birth. So I kind of like to frame that conversation with women in that way, that part of the role of the clinic as we see it is to try and smooth the way for her as she's accessing care through our Western medical system, and to try and aid communication between practitioners, to try and be clear on what she would like, what she's wanting, so that we can share that information between the healthcare team and of course with her, led by her, so that hopefully she doesn't have to keep having this conversation or encountering people who are kind of dancing around things or kind of making things a bigger deal than they need to in this way. A lot of the work that we try and do in the clinic is around education for our colleagues, for healthcare practitioners, for midwives, for doctors within the hospital, to try and just help guide them in conversations and how they might talk to a woman about her experience, her body, and what she's wanting. Definitely we'll talk to women about if they've got what we would be classifying as a type 3, talking to her about her options for birth, and if she wants to consider a defibrillation antenatally, which is what we would recommend for a number of reasons, which I can talk to more if you're interested, maybe in the question time. Definitely kind of, I kind of see it as kind of planning for her care, kind of also thinking about access to interpreters. Most babies like to be born in the middle of the night, which might make it a bit tricky to find an interpreter or, find a good team at that particular point in time. Also depends how much of a rush that baby is in coming. So if we can have had a really clear communication and made a good plan ahead of time, if we can document that really well, if we've given her, the language and the, this is what you need to say, or these are the questions that they'll ask, and this is how you can kind of have that conversation, then hopefully when she comes to give birth, we can hopefully make that experience as kind of comfortable, and she can feel as confident and grounded as she possibly can at that time. So this is just a slide, I guess, kind of outlining some of the things that we might do in one of our visits. We would always aim to work with one of our beautiful FARAP colleagues. A lot of appreciation and gratitude for the work that they do. We would be doing a kind of general health assessment. Like I said, a lot of the women we're seeing are pregnant, so kind of checking in on their antenatal care as well as general women's health. So as you can see, cycle screening, we might offer them STI screening if that's something that they might be interested or might be appropriate. All of that general primary healthcare, health promotion stuff, which I don't need to talk to you about. And as I think it was Shukriya said in her presentation, we try not to assume anything. As you will have seen in these presentations, we know that everyone is different. Every woman that we see has got a really different experience. She'll come to the clinic for any number of reasons, with any number of expectations or hopes or goals or desires. And so that's definitely something that I've really more and more learned, is to kind of really check any assumptions that I might be making, really making sure that I'm being led by her and what she's wanting from her visit. in the clinic. I guess just speaking to other health professionals and colleagues who might be at this presentation, I think I would really like to share, on that theme of not making any assumptions, just really, I guess just that, really not making any assumptions. I've met women in the clinic who did not want a defibrillation. She was really happy and didn't want any change there. So I guess just always just checking any assumptions we might be making about people and what they want. Thank you. The next slide is a graphic photo. I think great. So this is a photo of someone who's had what we would classify as type 3. I just want to assure you, as you can probably tell by the sterile drapes, this person has had anaesthetic, so she's not feeling what we're doing. But as you can see from the image on the left-hand side, just showing, I guess, how she's healed after the cutting. And this would be part of our assessment, but obviously talking to her very carefully about, as we do the defibrillation procedure, how we're going to do it, what would she like. Some women would like us to do the defibrillation just to the point that's going to kind of, I guess, enable vaginal birth. Some women are really keen for us to defibrillate as much as we possibly can, which can be very tricky sometimes, and sometimes we have to say, I'm really sorry, but it's a very, very sensitive area and we need to be very, very careful in what we're doing. So obviously we have a lot of very careful conversation before we do any of these procedures. Definitely as part of our assessment and in our consultation, if there's any kind of, so we're doing the defibrillation in our clinic, which is amazing for the women in that they can, especially those women who are traveling long distances, as we were talking about. She can come, we use a local anaesthetic, we do the procedure. If it's me, it probably takes about an hour. If it's Mari, she's a lot quicker. We make sure that she's comfortable and feeling okay to leave after, but then she can go home and we'll call her in the afternoon. And most women are amazed how comfortable they feel that day, the next day. Oh, thank you. And it makes it a lot more accessible as well, in that I guess it's like a day procedure. She might just take one day off from work. She might not even have to tell people that this is what she's doing. If she's organising childcare, it can be quite a discreet, not a big deal thing. Whereas if she needs to go to theatre, obviously that's a much bigger deal. She has to wait a lot longer in recovery. She might need to organise someone to help with transport. It becomes a much kind of bigger procedure. But sometimes there are women that we see that we will recommend that they go to theatre, whether it's an issue of getting a really good anaesthetic, or we want to ask one of our medical colleagues with a bit more surgical training, because we want to make sure that obviously we do a really good job when we do it. So here you can kind of see an outline of what we do when we're doing the defibrillation in our clinic. So we'll give the women a topical anaesthetic cream for them to apply before we even see them. So hopefully that's working prior to us using then a local anaesthetic, we use lidocaine. As I said, a lot of conversation around consent, talking about what we're doing. For those of us who are more clinically minded, obviously we're doing observations. It's a sterile procedure, and we use dissolvable sutures. So for those of you who might be interested, those sutures will usually dissolve within 2 weeks. And honestly, I think all of the women that I've ever called after a procedure, we'll call them the next day. We tell them they can call FARAP at any time. And then we'll usually see them 4 weeks later. And I don't think I've ever spoken to a woman that was experiencing pain or had any kind of complications or felt worried. Everyone that I'm not making this up, but everyone that I can think of has always said, I can't believe how much I'm not in pain, and how quickly I've healed. So that's really nice to share with women, because obviously she's probably feeling really nervous and really worried about how it might be and how she might feel. We definitely encourage women, now that we're post-COVID, or we don't have to worry about all of those COVID restrictions, we definitely encourage women to bring a support person with them. Sometimes they might sit with them, sometimes they might sit out the room. We always have 2 of us in the room so that someone can be doing the procedure and someone can be staying with her, or kind of just offering an extra bit of support as we need. Afterwards, obviously, we offer some Panadol. That's usually as much pain relief as she needs, and a urinary alkalizer, just because it might sting on the stitches afterwards. We just give her some tips on that. Debriefing, checking in, making sure she's feeling good before she leaves the hospital. And like I said, we followed up with a phone call and an appointment 4 weeks later. So in conclusion, I'm not going to read all of these points out to you. I'll let you read them. I guess I've worked in the clinic a much shorter time than Mari and some of my colleagues, but the longer I work in the clinic, the more I feel like I wish I had more time to do more, especially in terms of connecting our services and our networks, and kind of really offering a kind of cohesive service for women to access. I think often women can feel really alone as well. So I really like to, when they come to the clinic, kind of remind them that they're not alone, that this clinic's been set up specifically for women who've had experiences like theirs, and kind of connect them in with the services that we do know are available. I'm just reading through to make sure I haven't missed any important points. I think that's everything that I would like to say to this slide. Thank you. And then I think the next slide just has some of our contact details. So we're based at the Women's. Unfortunately, our clinic is only 1 day a fortnight. So our clinic runs every second Friday. So our next clinic is next Friday. Thank you very much.
Shukri, do you want to lead? We're just going to, give people a moment to take in everything that Mari, Rosie, Shukri, and Intisar have shared. We're going to go through a couple of case studies. That would be great to, Shukri, you lead those. It would be great to hear what those who are online have to think, and I will just be taking note of questions if you have any, because we'll have the Q&A session after this as well, so please pop them in the chat.
This is case study 1. So Kay is a 35 years old woman. She just had her first baby in Australia. Record shows that she had a vaginal birth and defibrillation before labor. Kay is upset because her body feels very different and abnormal. She wants to be re-infibrillated and wants to find someone who can perform the procedure. Kay is worried about her menstrual and urinary patterns has changed. She's also worried about her husband might feel if she didn't have a re-infibrillation. She's also worried that he might this might affect their relationship, and that he might leave her and look for another wife. How might you support Kay in this situation? Any response you have, you can put it in the chat. Next slide. These are some of the responses we think. So inform her about the reasons of the procedure was performed to deliver the baby, invite her partner during consultation together, inform both of them about the health implications of FGC, informed both about why she cannot have reinfibulation, and also inform them about the laws of FGC in Victoria, in Australia, and refer them to FARAP services for further support. This is another case study. S is 29 years old. She just had her first baby girl in Australia 6 months ago. She wants to know where she can take her daughter to get her circumcised. How might you support S in this situation? Next slide. Ask her the reasons of why she wants to circumcise her daughter. Ask this will help inform your responses. Inform her about FGC, the health implications. Inform her about the law in Victoria. Share your concerns with the parents and guardian. Document your notes, intention, and monitor the child. Consult with management if you have to. If you have assessed that reports need to be done to DHS. Inform family about reports that has been made. So this is something that actually did happen. So a couple of years ago, someone gave me a call who was working within maternal child health. They rang me and said, can you, I've got a client that is wanting to circumcise. Can you give me a contact detail of a space where we can take that child to get her circumcised? And I said, there is no circumcision service for young women. And so I had to explain. So I had to sit down and educate and inform this person who's doing the work, so the social worker and the maternal child health nurse. Then I was able to give her and guide her on how to respond to the parent and what needs to be done, the step-by-step guidelines on how she needs to respond. And if that means child protection needs to be involved, then that's something that she needs to do that. Yeah. That's it.
Thanks, Shakria. Before we move on to the Q&A session, we're just going to run through some slides about health pathways so that everyone knows, if they need to, about how to access clinical info and guidelines on referral pathways. So there's just a few slides where you can look at here, but we'll also, in the email that the PHN sends through, all of the resources that were mentioned earlier, the links and contact information for all of the speakers, as well as the health pathway information, will be sent to you afterwards. Information on registering and logging in to access all of that referral information. Okay. So Joanne, I might get you to join us now. And if anyone has any questions that they would like to ask, or any thoughts that they would like to share, please either pop them into the chat or turn your camera on, and you can ask them as well. I'm just going to check the chat now because I do think there was a question earlier. Yes, Shari was asking if there was any information to be shared around wound care recommendations for aftercare in case they see someone in their clinics.
Thank you, Shai. That's a great question. Maybe we'll add it to our presentation next time as well. Generally, we offer kind of really similar advice to what we'd offer women with seizures post-birth, if that's helpful to you, and just general wound care. So we'll, in terms of pain, we just recommend general like Nurofen, Panadol kind of situation. And like I said, a urinary alkalizer can just really help take the sting out of the urine, and all those other tricks such as like pouring warm water down when they pass urine or jumping into the shower. And really then it's just about kind of keeping it clean and dry. We're really lucky in Australia that our shower water is drinking quality water. So that's fine to jump in the shower and just keep it really clean and pat it dry. The stitches will have little knots, so it can be a bit sensitive. So we just talked about patting it dry. Women tend to, I haven't really heard women having any issues with bleeding afterwards. Mari's shaking her head as well. It's just not, we talk about it because we kind of have to from a informed consent point of view, but it's not something that we've ever had women experiencing. Excuse me. And you'd be amazed how quickly, I know it's not, you know, mucosal tissue, but it's quite amazing how quickly it heals up, honestly. It's quite incredible. Even within a few days, women are noticing that it's starting to heal up. Do you want to add anything?
Just, we've only had a handful of women, if that have had any kind of infection. I can think of 2 or 3, and they've needed oral antibiotics. And the only other complication we've had, I think we've had about 2 women come back and not all the sutures have fallen out. So we've had to remove a couple of sutures, but otherwise there's just no complications at all, thank goodness.
Most women we see, like, they don't need to use pads or anything like that. It really, they do seem to really recover quite quickly and quite comfortably. Yeah, I hope that answers your question. Please let us know if it doesn't.
Great. Yes, the person that asked that question said fantastic info. Thank you so much. So thank you for that. We also have a question from Liz asking, and I'll put this to all the speakers. Do you see women from non-African backgrounds? And is there any data on women experiencing FGC in Victoria that are from non-African backgrounds?
I'll jump in because we've got our mic on and Intisar so he can interrupt. Yeah, we definitely see women who have come from countries outside of Africa. I've seen women who were born and grew up in Indonesia and have told me that it's, she was saying it's really common for her in where she was from in Indonesia in her community. And as Mari kind of alluded to, it is tricky, the name of our clinic. If anyone has any bright ideas on a better name for our clinic, please let us know. And we've heard stories of women from other kind of Asian countries who have also experienced FGC as well. Does anyone else want to?
We've had 1 woman from India.
Like it is, I think, medicalized in Indonesia, especially type 1, under Gen 1 study.
Yeah.
Joanne?
I just wanted to make a couple of very, very quick comments about the general practice context, if I could, for this subject. So just to explain, my context is caring for a lot of women, mainly from African backgrounds, who have come often on humanitarian visas. So this is, I guess, another perspective, and I want to also agree with what our presenters from the Royal Women's said. So many women that I see, it's not actually an issue that they bring up as front of mind. And I have many, many women who would never raise this as an issue with me. They don't actually seem to suffer a great deal from symptoms or problems. And occasionally when I've asked them about it, they say that, you know, they don't have a lot of problems that they talk about. So that's one piece. And I think respecting their wishes and their comfort. I wanted to put that out there. The second thing is, when would you discuss this with people? So sometimes when people arrive on as refugees, we do new arrival health assessments, which I encourage everyone to consider if they're looking after someone who's come from overseas on a refugee visa, or even someone who's come from overseas on a spousal visa and hasn't had that sort of a checkup. I often don't raise this topic as the first thing. I would get to know the woman first before I offered a gynecological examination, before I took any sensitive history, and I would always make sure, where possible, that she was on her own, or that I had a female interpreter to do that, and that I was going to ask her about women's business. That's often how I phrase it. And often when I do that, the male partner runs out of the room screaming because they don't want to know anything about women's business. So that is usually a context. The other context would be, you know, when the woman is planning pregnancy or comes and finds out that she's pregnant, or if we're about to do, you know, if she's due for some sort of CST screening. So it's usually, I ask about it in a context. I think it's important not to come away from this session thinking that we should ask about it whenever the woman comes in for whatever reason, e.g. she comes in with a cold and we ask her if she's had the traditional cutting. That would be not a good idea at all, I think, and women will find that extremely confronting and insulting. So I think have a context for where you will ask this question, and you will do very well. And the other thing I think as a GP is to ask about this in a very calm, professional, almost offhand manner, as in not to make a big song and dance about it. I remember the first time a woman disclosed this to me, I burst into tears and she patted my hand, which was very, very unprofessional. It was many, many years ago. But now I ask about it in a very routine way, as if asking about immunisations. And I think it's very important that we ask about it in this very calm, professional, respectful manner. As our other presenters have said, women have had all kinds of experiences. They have all kinds of thoughts about it. We need to engage them. We need to make them feel comfortable, to express whatever thoughts they've got about it, to give them support if they need it. And the best way to do that is to be calm, friendly, respectful, and non-judgmental. All right, that's where I want to stop.
Can I please add something to what you just said? Just to share some of my experiences from working in the clinic, which is because a lot of the women that we see might have been referred to the clinic from the antenatal clinic. And sometimes she's very clear on that referral and why, and sometimes she's not, especially if there's a language barrier, or there's a lot of other kind of issues in her pregnancy. And so understandably, she's kind of like, which clinic is this and why, and what do you want now? And it's been similarly, as someone from a Caucasian background in Australia, it's been a real learning experience, and really sad for me to kind of hear from women how worried they are of feeling judged by health practitioners in the system. And you get a real sense of kind of getting ready to hear from me that I'm going to tell her how terrible her family is, or how could someone blah, blah, blah. And I think I hope that's not an experience that women have had, that's kind of making her feel that way. But it's something that I like, as you were kind of saying, Jan, I like to try and be really, really careful, you know, of someone not of African descent, to kind of be really mindful of that, to be like, I'm not here to make any judgments or assumptions here at all. This is for you.
Thank you, Joanne and Rosie. We've got one more question here, asking if there's any recorded outcomes on the effects of relationships from the defibrillation procedure. And do you know anything about how their husbands respond when being told, and what, if any, disruptions in the relationships are being seen?
The women that come in for a procedure, if they're married or they're getting married, wouldn't do it unless they'd discussed it with their husband or husband-to-be. So it's already been discussed. Occasionally the husband comes in They don't come in very often. They are very scared of women's business, so they don't come in. We're very welcoming. I've had probably 2 in all the time who are with their wives when they have their procedure, and the 2 that I've had have just been amazingly supportive. Very brave thing for them to do. So yes, they wouldn't be coming in for a procedure unless they had discussed it. Look, we haven't done any audits. We would love to. All the feedback we've had from the women is that it's made a huge difference to their life, and they're very, very happy. And there are a few that still would like to go down the track of exploring their sexuality a lot more, because they're feeling that they're not probably getting enough pleasure from their being sexually active, or they just feel their relationship and their own sexuality needs more exploring. So, which is, as Rosie said, we have one clinic which doesn't have many practitioners doing psychosexual counselling, so it is a long waiting list. And sometimes we find they don't sort of go the first time to that clinic because it's another clinic, and it's such a huge thing for them to discuss. So yeah, we've got a lot of work to do in that area. We as clinicians would like to have more education ourselves. We talk about anything that the women want to talk about, but we would like to have more education ourselves so that we could go into that a lot more deeply. Yes, but no, I don't think there's never been any negative. No. There's never been any negative. We've had a couple of women come back who have asked to be defibrillated a little bit more, and when we explain what we're going to do, and when we are actually doing the procedure, we always have a mirror. We always have a mirror everywhere. So sometimes the women are too shy and they're not interested, but often when we examine them the very first time, we will say, well, we always say, we've got a mirror, would you like to look, so that we can actually have a really good discussion? And that's up to them, of course. But we have women that we have the mirror there while they're having their procedure. They actually really want to see what's happened. One woman, this was years ago with one of my other colleagues, she was literally telling Helene how she should be doing this. It was very funny, like, it was very, I can never forget it. But these women had come back because, as we say to them, we do our best on the day, but once they've healed and they're being sexually active, they might find there might be just a little bit more that might need opening up, a little tiny bit more, because it might be catching or just a little bit uncomfortable. And that's only happened a few times, and we leave that really open and very comfortable for the women to come back and have that discussion. And we have done a little bit more of a defibrillation for them.
I've got 3 very quick points. The first is I've learned never to make assumptions about the relationship and the man's attitude towards this situation, and always, again, to ask respectfully about the relationship and concerns and so forth. The second thing is I've learned never to underestimate the woman's capacity to be sexual, to enjoy her sexual pleasure, to commence relationships. And I've learnt to really respect that, and always, including with young unmarried women, to always never assume anything about behaviour or attitudes, and always offer the same level of care and questioning that I would offer to any female patient. And the third thing that I find very comforting is the fact that an Australian urologist, Dr. Helen O'Connor, I think her name was, very famously dissected women's sexual apparatus and found it was much bigger, in fact, and widespread than male sexual apparatus. And so there is still plenty of capacity and plenty of nerve cells available, which I find very comforting.
Actually, our head of unit of psychosexual counselling has now got I don't know what you call it, a mannequin of a clitoris. It's amazing, so that she can have it for her clinic, yeah. And I have to tell you one story about a woman that came into our clinic. It'd be years ago now, probably 6 years ago, easily. She was a woman, I think she was late 50s. She had been married and had 4 cesarean births, and she was getting remarried. She came for her defibrillation because she wanted to be able to enjoy sexual life with her new husband more. So yeah, never assume anything, even age.
I can share one quick story about, because I think the question was about male partners. One of the very first kind of consults I did was a really young couple. They came in together. And I'll always remember, you know, you have these experiences that you'll always remember, but I was just so touched by him sharing his kind of concern and worry that sex wasn't comfortable for them and for her. And he was really confused and worried about why that was. And it was this kind of situation where she didn't really know much about FGC and what had happened, and that, you know, there were a lot of kind of blanks there as they were trying to work this out as a young couple. And it really, really touched me, you know, that he was kind of like, you know, am I doing, you know, is it me? And it's like, no, there's a lot happening in this situation. I just wanted to share that experience in terms of questions about male partners and their feelings. Yeah.
And we've talked a lot about it. In the countries where FGM is practiced, I mean, I don't know, but I think the males knew a lot more about what the women had been through, and whether it's because a lot of them have come out to Australia as young people, there hasn't been that conversation maybe between the men to actually educate the young men, because, you know, I've had a few couples come through in exactly that same story, and it's really, really, it's quite distressing, obviously, but yeah, it's that cultural change. You've come to Australia, like, you know, and there's just no discussion or, yeah, any sort of education, or, I mean, I don't know, but this is just what I you know, we've sort of talked about, yeah, which is really hard for all of them, you know, the couples.
Thank you. Intisara Shakriya, was there anything that you would like to add?
Not really, but I'm just impressed with what the Royal Women's Hospital is saying. That's the main attitude change about this, and you know, I can see it in real life as well. They've been supportive, yeah, to their wives. They've been supportive to their girls. They don't want to do it, which is, and that goes back to the education that we're doing. So I think for you know, other work that's happening for you know, to eradicate or stop FGC is going really well. So it's reaching men, women, and young kids.
I think one thing we need to understand around FGC, or the women who've had FGC from the country of birth, is that whether it's type 1 or type 2 or type 3, so women really don't attach implications of it like right on the spot. Like if they don't see, you know, the long-term outcomes is something that they might go through after they've for example, after marriage. You know, some women who, for example, have type 1 and type 2 might experience less sexual pleasure. And that's the only time they know is once they get married and they have their partner. And then at the same time with type 3, it's because like I've been through the high school system where sex education was provided, and you know that there is this ideology around what a normal vagina is, what, you know, cut or uncut vagina looks like, and some of the young people or women in general would have no idea that there is something wrong with them, or the way their vagina looks is very different, and so like there is definitely a need of education around sexual and reproductive health, around empowering women, around giving women the ability to make that decision around their sexual health and well-being, and reproductive health is very important. And I do think, you know, like doing both, where like we're providing services that training, that ability to recognise and ask questions, but also supporting women in the community to do that.
Absolutely. Thank you, Shakriya. Are there any last minute questions that people have? Might give you a moment to have a think, and also just draw your attention to the link which the PHN has just popped into the chat. So that link includes questions from the PHN, but also ones that we, the speakers, have developed, and it would be really, really helpful if you could just spend 5 minutes filling out the complete survey, because those responses really let us know what to include in future sessions for healthcare professionals, sessions like these that we do together, but also work that Shakriya and Intisar go out and do when they do health professional education, the clinical information for Joanne, Murray and Rosie to improve their services, but also lets us know where Tilly is, but how we can get our other FARAP workers to expand their community education. So there's lots that we can gain from your insights and your responses, and also, yeah, just helps us make these sessions better and more tailored to what people are needing in future. So you can, yep.
Sorry, Sarah, just one more thing. I hope we made it really clear that we take referrals from all over Victoria for our clinic.
Yes, good point, Murray. And also, yes, just a reminder that your contact details about the referral pathways for the clinic, as well as details for Shakriya and Intisar and other FARAP workers across the state will share with attendees in an email after tonight. I think we will leave this slide up for about another 5 minutes to give people time to complete it. And then speakers, if you don't mind, we can stay online just in case there's any last minute questions as well that come through. All right. Well, hopefully everyone had time to bring the link up on their phone. I want to give a huge thank you to everyone who attended tonight's session, and also a huge thank you to each of our speakers. I've listened into this content before, but I learn something new every single time, and it's so great to hear about the work and the approaches of the clinical perspectives, but also our fabulous FARAP workers. So thank you, everyone.
Thank you, everyone.